Hey guys, it's Mike, and I'm back with Tom, and we are here with another billing and coding update, and we are back by popular demand with more critical care. We have one more case example, and we've gotten a lot of questions about this over the last week or so.
Yeah.
What do you do with critical care in the DNR patient?
Absolutely. So, and by the way, we stopped numbering our billing and coding pearls.
Well, I lost count.
Right, we can't count that high.
Yeah.
So, okay, this is case 10.
I had to take my shoes off.
You can read the slide, but basically it's a altered mental status. It's a patient from a nursing home, not acting herself, nonverbal, couldn't stand, followed commands, but definite had some right-sided weakness. There some documentation of discussion with the nursing home about what meds the patient's on. There's a guardian that they couldn't contact.
Right.
They talked to the son, but the son's only a co-guardian. This will all become important later. So the patient's DNR, DNI. So there's a physical exam that talks about, unable to speak and the neurologic changes.
Sounds very much like a stroke.
Sure. And so now we've got the assessment differential diagnosis. So we've got acutely ill, we've got a differential that's broad.
Pretty good differential.
Exactly. And this is what they're going to do. So there's now documenting what happens, and there's a big left-sided subdural fluid blood collection with critical mass effect. So we keep going through the course, and we get to the medical decision. Now, understand, this is all from a real chart. This is cut and pasted from one of our records.
Right. We took the names out. Well, we actually didn't take the names out. We took the numbers out to protect the innocent.
God, I can't believe we left the names in. Anyway, so there's a large subdural on aspirin. They talked to neurosurgery. We're going to give them some FFP. They discussed with some family friends who's no longer the guardian. But there's some concern. It's the patient DNR, DNI. Then they talk to who the person they think is the guardian. Then they talk to Jewish Family Services. Then they discuss with the transfusion service. They don't recommend FFP, recommend platelets, and they talk to the ICU when they're admitting. So here's the critical care note. So CNS is the
very appropriate.
Risk, bleeding.
Very appropriate.
Chest X-ray. Still
5 minutes. 5 minutes seems like a long time. 5 minutes is so long.
1 or 2 minutes is all you need. Management. Bedside management, test review, record review, all seems to make sense. 35 minutes, certainly it's probably longer than that based on everything we saw. 40 minutes is appropriate because it's more than 30, even if you take out the 5 minutes for the chest x-ray.
Right.
And they didn't exclude any procedures because they didn't do any. So, can you bill critical care in a DNR patient?
Maybe.
Yeah, it depends. So Medicare pays close attention to DNR patients and critical care because they ask the question, if the patient is DNR, why are you doing critical care? So you can, DNR does not mean do not treat. It means do not resuscitate. So you have to document, and this chart I think does a very good job of documenting an attempt to figure out who the guardian is, who's making the decision, and what are we going to do, and how that interacts with the care in the emergency department. So sometimes you get a patient who's really sick, and you do all this work, and the family comes in later because they weren't there available when you first got the patient, and they say, hey, it's comfort care only.
Right.
But you've already done 30 or 40 minutes of critical care. In that case, it's perfectly appropriate to document the critical care that you gave and then stop.
Right.
But the note needs to be clear. And then the timing's critical. So when was the decision made, or when were you aware to stop providing critical care? And then, of course, we mentioned this the last time, someone dies, critical care
stops. Right.
No matter what.
Right.
So, yes, you can document critical care in a DNR patient, but you've got to explain what you're doing, why you're doing it. And, we have patients that have DNR, and they come in septic, and the family says, yes, we want antibiotics, we want fluids, we want pressors, we just don't want intubation, and we don't want CPR.
And I think it's very appropriate to provide those things and document and be paid for it.
Absolutely. No question about it.
So I think that's everything that we have on this case.
I think so.
Or do we have another?
So medical decision-making pearls, just to give you one more slide to look at.
This is a freebie.
It's a freebie.
It's a bonus.
And in your medical decision-making part of your chart, tell the story of what happened and why you did it. We love time progress notes.
You know how much I love time progress notes.
If you give a medication, what did you give? Why did you give it? And then response to treatment. So, did the wheezing get better? Did their pain get better? Those are all parts of medical decision making that will help you with critical
With
care.
critical care as well. And
with any patient. That you
any
take care of.
patient at all. Yeah.
So, all right.
So there's a bonus slide.
I think that bonus slide pretty much ends this billing and coding pearl.
As always, if you guys have questions or comments or concerns, please shoot us an email, and
Right.
we will address them in future episodes. Hopefully, you guys have enjoyed the critical care review that we've done over the last few weeks, and it's been
We've tried
helpful
to
to
hit
you.
a couple of areas that seem to cause a little bit of confusion. Bottom line is, you're not documenting enough critical care. I can promise you. Stuff that seems routine to you really isn't.
Right.
If you think it's going to give the family practitioner down the street a little bit of heartburn or maybe soilless drawers, then you should build critical care for it.
Yes, absolutely.
Not to say there's anything wrong with family practitioners down the street.
I won't send this to them. So.
No, okay, good.
All right, till next time.
All right.